This episode is brought to you by Contact.io. Contact.io delivers outcomes, not just boxed hardware. Unlike legacy RTLS software, their AI powered RTLS platform supports better healthcare operations, immediate response for staff safety, 75% fewer equipment rentals, and 20% shorter lengths of stay. With a pricing model designed to deliver ROI in months, not years, Contact.io makes it easy to scale quickly and ensure operational excellence. Keep your staff safe, productive, and equipped to provide exceptional care at the right time, every time. Join leading health systems already transforming care with Contact.io. Learn more at thisweekhealth.com/contact-io. That's KONTAKT-IO.
Welcome to This Week Health. My name is Bill Russell. I'm a former CIO for a 16 hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Now, on to our interview.
All right, here we are from HIMSS 2025 in Vegas, and I am joined by Philipp Gilsa with Contact.io.
Contact.io?
First of all, I want to start by saying thank you, because we have this check behind us. We raised close to $40,000 for Alex's Lemonade Stand and pediatric cancer, and you guys are on them. You guys were one of the sponsors for that.
Cut the logo in, but yeah.
Yeah, we have to cut
we supported it big
the
time.
logo's behind me over here, but that was the golf tournament. I didn't see you at the golf tournament, though, so you were busy doing CEO type stuff, I assume.
Yeah, and family. Those are like my competing priorities.
I can imagine. A lot of people, I would imagine, aren't familiar with Contact.io. I know when I first met you, I wasn't familiar with Contact.io.
Yeah.
I want to start there. Give us an idea of what Contact.io does. What problem do you solve in healthcare?
Good. So taking a step back, Contact.io is a next generation RTLS enabled AI company. There's a lot of different terms and buzzwords, so let's declutter it for a second. If you want to put us in an original box of what is the technology spectrum, then it's RTLS, real-time location system. Have been around for 15, 20 years. If you were to survey all the CIOs within the 2 to 9 group, I would suggest that probably 95% have heard of the term before.
Oh, absolutely.
The experience that they had, if you were to give them...
was mixed.
Yeah, I would say probably 70% have had a negative experience of some sort, and it mostly had to do with the idea was great. We could track our assets, we could understand where stuff is, we could optimize and automate safety workflows. We can see the patient move from admission to discharge. So the entire idea of essentially creating a digital twin of care delivery operations, understanding how space, how resources, and how staff are orchestrating and circulating around the patient is not new. It's been around, right? And I think in the first era of digital twin and IoT, all these things have been around for 10, 15 years. I think the core challenge is that it has never been successful at scale, which is to a big point a technology problem that 10 years ago was on-prem, it was proprietary technology, it was heavy big tags, you had to unscrew and put in new batteries. It was just the operational cost of creating data, if you abstracting, was just too high. So everybody tried, and especially the rich health system tried, they burned themselves in, and then they never really touched it at scale again.
So the first buzzword you gave us was next generation.
So next generation, so what does it refer to? We come in, and I start with the value proposition and not explaining the technology details. As we said, we're going to go after this industry and fix it. And we fix it by saying if we make it scalable, which is a technology argument and it's a cost argument, right? So it needs to be a third of the cost, not the same. It needs to be provided as a service and not giving a whole bunch of hardware and CapEx and then it's your job to deal with it. We want to make it fast. Fast means getting the technology into a hospital fast. For us, a 200-bed hospital, 5 days. We come in, we go out, you go live. 5 days, unheard of.
That is unheard.
Which also means that unlocking value becomes fast. If IT is not the bottleneck, if you can develop a process and you have the supporting technology to go live in a very short amount of time.
Cloud-based as a service.
Cloud-based as a service and a fraction of the cost.
And the implementation, does your team come in and do the implementation?
We do it end-to-end, the implementation. And it's not even a separate line item, take that. It's part of the service that we provide. And that has allowed us to go in, and on average, we are roughly 14 times faster than a first generation RTLS system. We have deployed the largest health system in the world in 9 months. And you were talking about every single hospital in the health system.
Yeah, which is
you go to the booth and you see the
yeah, you can see the
and you can see the name. Yeah, fast, scalable, and easy. And easy is mainly looking at the user. If it's a nurse, if it's an equipment engineer, if it's a patient flow coordinator, technology these days needs to be easy. Yeah, and how do we achieve easy? We can now go a little bit deeper. So we've decluttered RTLS and next gen. We'll talk about AI in a second. But
before we get to AI, we have to talk about money. I'm a CIO now. A lot of pressure on me for money. Reimbursements aren't going up based on what's going on in Washington. They were never going up, but
and it's going to get worse.
It's going to get worse. So they're going to come to me and ask for more money. Talk to me about the ROI on this. I love the fact that literally I can turn the key and this thing starts. And if I'm a 16 hospital system, you're essentially telling me we could be implemented in
if you
16 to 20 weeks.
Exactly. If you're a 16 hospital system, our value proposition to you is that we are going to create a hard ROI in the first year. And by hard, not saying productivity gains by helping a staff member to do something better with less or anything, but we're taking an hard ROI stance, which typically starts and happens within the asset domain, because the amount of equipment these health systems purchase, the average utilization rate, if Doge would look into that, they would say this doesn't make sense. You guys are buying to this, right?
Yeah.
And so, joking aside, with basic visibility, if you have basic visibility, then health systems, especially if they're larger, today they either own or they rent. Private equity industry has done phenomenal business around equipment and services that you provide by not owning an IV pump, but by renting it. And with, I want to say, the large health systems that are in the renting business, our ROI happens in the first month. Because we come in, we tell you that the average utilization of a given category of equipment, like a pump, is at 40%.
So you don't need this stuff anymore. Essentially, you come in and say,
yeah. We come in and it's a rental contract. You go live with us on the 15th of October. On the 1st of November, we tell you which assets you can deprecate and or defer future CapEx spendings. And so very often what you'll see is that our sponsorship within the account that we're working with is an alliance between the CFO and the CIO, because we're essentially empowering the CIO not just to drive cost savings within the IT department in the group, which obviously happens if there are multiple outdated vendors. You can consolidate, you can do the same thing better for a lower price point. But if the reach of the CIO organization is truly going into the operations with hard and measurable ROIs, and we have templates and we put the governance around it, because we pretty much understand how a 10 hospital system and a 150 hospital system are operating on the business case sort of logic.
So you just gave me,
help you drive cost saving.
You just gave me one instance of the data I'm going to receive, which is going to help me to save money. But I would imagine this is going to generate a ton of other data. Is this where we start talking about AI and how
That's why we're talking about the AI. If we go again back into this industry, then the first generation approach was, here's the technology, here's the hardware, here's the data.
Yeah, you figure it out.
And if you were to start a company in that space, you don't have to be a magician to say, that doesn't make sense. How about we start focusing on outcomes? How about we start putting contracts around outcomes? How do we deliver outcomes? You are, I think, probably similar to me, all the latest and greatest agentic AI, ChatGPT, LLM-based technologies to improve your personal or your organizational workflows within This Week Health. And the same thing applies to operational domains within the hospital. And we almost say, if you walk the floor here and you categorize anything that you see that has the tech AI to it into clinical and for hardcore operational kind of back end, but where the real cost within a hospital organization is sitting, you'll find that a lot of stuff is happening in clinical, diagnostics, ambient listening, all great, but there's a big chunk of challenges that go beyond just the asset domain that sits within operations. And that's where we're focusing on. And if we deep dive into the use case domains, then we see the world in kind of three buckets, if I were to simplify it. We always start by looking at the asset because it's easy, it's a known quantity, and
it's a quick ROI.
You can get the entire initiative and us as a new vendor funded. Then we move into the domain of staff workflow and staff safety. Here, it's the entire idea. I have one on me. You have a mobile arrest button. Workplace violence is on the rise. There are, sadly speaking, attacks on nurses. I think every other week you read about it in the news. And providing a portable arrest button addresses a lot of the issues that's part of a broader kind of workplace violence prevention program. And it has CEO visibility. Like the largest health systems in the country are putting RFPs out to go after this. The last domain, and that is probably the most interesting domain when it comes to now the real application of agentic AI specifically, is the domain of patient. And the patient is, if you look at it from a location problem, it's about flow. It's about how do you move through admission to discharge? Where are the barriers? Where do I wait? How can we improve resource decisions? Where's the next available bed? Where's the next available IV pump? When was the last rounding visit? And can start correlating and putting this into connection to a length of stay, capacity management domain, both in the inpatient, but also on the OR side. And here, I almost say AI falls into two buckets. There's a good old machine learning word of let's build simulations and predictions and provide recommendations of what needs to happen in care delivery to unblock issues that are affiliated with patient flow, which ultimately is a revenue topic. And B, which is agentic AI, which is essentially the idea of instead of building fixed rules around if this happens, then do that, you build rules that are objective driven rather than constraint driven in saying there's an agent that helps me manage bed capacity on a given ward. You can start feeding rules with location data, combine it with EHR information, and then provide phone interfaces, chat interfaces to unlock that data. And that's where we're rolling.
You end up consolidating multiple systems, not just RTLS, but other systems that they're utilizing?
Yeah, we integrate with essentially a variety of systems. I think when we went live, we met at like a two-way integration.
It just goes right in.
Yeah, like we either feed into their workflows or we consume data from the CMMS that can sit within Novolo service.
This is a silly example, but
and the same with the EHR.
I was as part of a committee that was looking at the grass situation on our golf course. And we were like, hey, what would really help us is some information. They go, you know what, all of our golf carts had GPS. And they gave us a map that showed us where everybody had driven. And we could see the places where they had driven a lot, where they had driven a little, and that kind of stuff.
Yeah, and then they block your car if you're going out of a specific area.
They have that too, but what we were trying to do is figure out why the grass was dying here and dying here. And it turns out, if you just look at the data, and it becomes very obvious. That's the kind of data over time you get to see.
And it's the same thing. Look, the last time I was an inpatient, or my wife was an inpatient for giving birth, and was in an amazing New York-based hospital system, the amount it took us to get discharged, and like the process, when you're like, okay, you guys are ready to go. And you're like, the discharge order gets written, you're like waiting there for 2 hours, then they're going to call transport is not available. I, at the end, discharged my wife myself. I grabbed the wheelchair, put her in, and I know I wasn't supposed to do it, but these are very small inefficiencies that at the end, if you think about 100,000, 200,000 patients, they have massive impact. And health system on the operational side, it's not that there's this one big thing we have to get right. It's death by 1,000 paper cuts. And because of that, you need to have decision-making systems and engines that try to automate and orchestrate the majority of these type of decisions. For a clinical engineer to call and say, hey, we're out of IV pumps, let's request another fine. That is type of decisions we probably both agree without being experts in the domain. You don't need a person and that AI could take care of, right? Without understanding exactly how it's being built and what it's doing.
Does your conversation start with the CFO or does it start with the CIO?
Really depends. Typically, the CIO is the most critical role for us because any large health system has multiple initiatives around some of the point problems I've talked to about. Staff safety, you have a security person, maybe they're partnering up with the nurses looking for one specific solution. So you have the same on the clinical engineering on the HTM side. And so only the CIO is capable of seeing these multiple initiatives and then coming to a conclusion that, hey, if we do something in the domain of location, it doesn't make sense to go with one vendor for this solution. You need to think of this as a platform data play, and we're going to make that decision. We're going to look at that solution, and then we're going to work with the different business stakeholders that want to have specific requirements to bring them live on the platform through user management and all these things.
Wow. This is a great conversation, by the way.
I don't know what we're doing.
This is, and actually, for me, it was interesting because I took the approach of, I'm a CIO meeting you for the first time. Let's talk about this. When I get to the end of this conversation, the thing that strikes me is I can go have the conversation with the CFO if the CFO hasn't been involved. I could go have this conversation with the chief medical officer. We have to be careful.
A friend in like anywhere in
here, the chief nursing officer. There's a whole bunch of people that would be like, thank you.
Yeah, and listen, I do want a big shout out to our, I think, mutual friend, Chris Paravati.
Yeah.
They're one of our early customers on the staff safety side. We're protecting 10,000 caregivers over the Northeast Georgia Health System. The interesting thing is, I just returned, Chris and I met up, I think last Monday, and we're doing a workshop with the entire executive team. And it was essentially the CIO sponsored it, and the entire C-suite came together and said, what can we do next? And we went in, we did a workshop, and we rated it, and we came to a prioritization of those are the specific problem domains that are most relevant for the different stakeholders. And I feel this is also from having listened in to some of the CIO conversation in 2009, I think that's where the role of the CIO is evolving, being that true business sponsor to the executive group. And
by the way, that's the definition of a platform right there.
Yeah.
When you're done, it's not, we do everything this application does. It's more like, all right, as a leadership team, what else could we do? We have this data, we have this tool, we have this capability now to look at things a little differently. What else can we do?
Exactly. And I think it's the one statement I made at the beginning. I think we have at one point of like our website, we like to focus on the boring stuff, because another issue is there's so much hype around AI and AI for this and AI for that. We take a very firm stand of saying, look, there's a lot of waste within operations. I think we all agree on that. Let's fix the things that are right in front of us. It's also a domain where applying AI is much less risky than in clinical decisions. And so it's a low-hanging fruit by driving and converging what you can do with AI, plus where do you focus these initiatives. Plus there's a hard ROI. We feel that the kind of macro environment is actually supportive and probably a reason we've been growing significantly over the last 24 months.
Fantastic. Philip, thanks for your time.
Thank you, Paul.
Thanks for listening to this Interview in Action episode. If you found value in this, share it with a peer. It's a great chance to discuss and in some cases, start a mentoring relationship. One way you can support the show is to subscribe and leave us a rating. If you could do that, would be great. Thanks for listening. That's all for now.